Good afternoon, but also good morning and good evening to many of us. It is our pleasure to welcome you to our second webinar in the series of ITM alumni webinars featuring the ITM winners of the Prize for Global Research 2021. This prize is awarded yearly by the province of Antwerp to research projects of master after master students of ITM and other higher education institutes. Development, relevance, quality, and originality of the master theses are key in the selection. Through this award, the province of Antwerp wants to stimulate research relating to the Global South. In this second webinar, MPH alumna and laureate Tatiana Mvilongo from Cameroon will present her master thesis entitled The Fourth Target as a Strategy to Improve the Fourth 90 Target, as a strategy to improve health-related quality of life of people living with HIV in sub-Saharan Africa. The main aim of this series of alumni webinars is to share research findings, expertise, and experiences on a specific international health-related topic within the ITM community of alumni, students, staff, partner institutions, and the wider global health community. I will now briefly explain some of the practicalities related to this webinar. If you want to ask a question, you can use the Q&A option you will have below your screen. You can ask a question anonymously if you would choose to do so. The chat is being disabled for questions. Questions will be moderated and only a select number of questions can be answered in live given the limited time. Unanswered questions cannot be answered individually afterwards, for which we apologize. At the end of this webinar, a short survey will be displayed and a browser window will open to give your feedback. The webinar is being recorded and will be made available afterwards on the ITM alumni platform. Our today's moderator is Tatiana Nöstlinger, clinical and health psychologist. She works as a senior researcher at ITM's public health department with emphasis on HIV prevention, sexual health promotion, and systematic development of behavior change interventions. Please, Christiana, the floor is yours.
Okay, thank you very much and welcome everybody. I'm very happy to have been asked to moderate the session and Tatiana later on will present her master thesis. And I would like to give a very brief introduction. And I would like to start by saying that maybe one of the biggest changes in our efforts to end HIV and AIDS on the global level has actually been treatment as prevention. And it's a bit funny that me as a psychologist, I should say this, but changing behavior as prevention, and in particular changing sexual behavior, is quite complex. And in comparison, treating people for HIV and at the same time also having a prevention benefit seem to be more straightforward. And in fact, it has turned out that when people are effectively treated, they cannot pass on HIV to others. So this has been an enormous improvement and achievement, which really has normalized the lives of people living with HIV. Although we also have to acknowledge that there is still a great deal of stigma and discrimination attached to HIV. So in the end, we have to acknowledge that HIV is not just as an infectious disease, but it's really a kind of a social disease. So I've said that people living with HIV can have sort of a normal life, but we have also seen that having suppressed viral load levels, and meaning being treated effectively and not being able to pass on HIV to others, it also comes with many other challenges attached to this chronic condition, which means that people are living longer lives, but not necessarily are they living well with HIV. So we really need to create awareness and also accountability towards the overall health of people living with HIV. And that would mean not measuring only the medical outcomes, but also their self-perceived quality of life and to really also perceive it from the patient's perspective. So measure patient-reported outcomes. And so this has actually led to what is called this Fourth 90, which was an idea and an initiative to beef up existing global targets with that kind of new benchmark. And Tatiana will tell you a bit more about that. So this is more in line with the HIV continuum of care, meaning that we are measuring the number of people who are diagnosed, the number of people who are put on treatment, and the number of people who are effectively treated. And so how does quality of life fit in with all those targets? So far, this Fourth 90 hasn't really materialized, but the debate is going on, and Tatiana, in her master thesis, she really has shed light on the various challenges that are related to this Fourth 90, and also about how to measure and potentially improve the quality of life of people living with HIV. So I want to be short here, and I would like to give the floor to Tatiana so that she can elaborate. Thank you very much. Thank you, Tatiana. The floor is yours.
Okay, so thank you, Dr. Christiana, for introducing me and giving me the floor to talk about the Fourth 90 target as a strategy to improve the health-related quality of life of people living with HIV in sub-Saharan Africa, using a scoping review methodology. So HIV has been and is still a global burden worldwide, with about 38 million people living with the infection. Sub-Saharan Africa remains the region most affected by this epidemic, especially in terms of new infection, as it accounts for almost 2/3 of all infections worldwide. To address this epidemic in 2014, and especially to scale up HIV treatment and testing, the Joint United Nations Program on HIV and AIDS set up 3 targets called the Triple 90 targets, aspiring for 90% of people living with HIV to be diagnosed, for 90% of those diagnosed to be placed on treatment, representing 81% of the total population of people living with HIV, and for 90% of those placed on treatment to achieve viral suppression, representing 73% of the total population of people living with HIV. Here we are going to define viral suppression as a level of less than 1,000 copies per ml in the blood. This third step is important because in the absence of an effective vaccine and cure for the HIV infection, finding a therapy that could reduce the amount of virus in a person so low so that HIV transmission becomes negligible was a monumental step in the management of HIV. So because these targets were policy bound, every country around the world tried to achieve the goals, creating a lot of progress when it came to clinical management of HIV worldwide. Unfortunately, this progress was much slower in the sub-Saharan African region, where testing and treatment remains a challenge. As such, we could identify some gaps in the cascade. But the most important gaps occurred at the second step, treatment uptake, and the third step, viral suppression. I'd like us to zoom into again the third step, viral suppression, because we now know the importance of getting people living with HIV virally suppressed. But we see that by the end of 2019, almost half of the population of people living with HIV were still infectious, meaning that they could pass on the infection to others. So the question remains, why is it that despite the wide availability of ART worldwide, it is challenging to get people living with HIV to have sustained viral suppression, especially in sub-Saharan Africa? We went ahead to do an analysis. In this analysis, we realized that there are psychosocial factors from the literature and even by experience such as stigma and discrimination that affect the quality of life of people living with HIV. Now, when the quality of life of people living with HIV is tampered with, this may affect their treatment uptake, adherence, or they may even stop their treatment. If they do any of the above, they will not be able to achieve viral suppression. If they do not achieve viral suppression, they remain infectious, meaning that they can pass on the infection, and they become ill because it gives way to opportunistic infections. When this happens, this further impedes on their quality of life, creating a sort of vicious cycle that always goes back to low viral suppression. So to address the psychosocial factors that seem to affect the quality of life of people living with HIV, a fourth 90 target was proposed in 2019. This target called for 90% of all people living with HIV from the point of diagnosis to have good health-related quality of life. It looked into success of HIV treatment that goes beyond just viral suppression. Unfortunately, the concept became heavily debated, leaving stakeholders indecisive and divided. The fourth 90 target was not added as one of the UNA's testing and treatment targets. So what we wanted to know through this research is what is the origin of the debate? What evidence exists out there to support strategies to improve the health-related quality of life of people living with HIV, especially in sub-Saharan Africa? Why did we want to know this? Because if psychosocial factors really impact the health-related quality of life of people living with HIV, then probably improving the health-related quality of life may address this gap that we have observed in the continuum of care. We also wanted to inform research and policymakers by mapping concepts and identifying research gaps through a scoping review. We set 3 specific objectives. The first was to retrieve information on the fourth 90 target to understand what the debate was really about. The second was to identify affected domains and determinants of health-related quality of life. And the third was to map interventions, more like an example of strategies that are being tested or ongoing in this sub-region of Africa. But because we knew that health-related quality of life is a multi-dimensional concept, we wanted to seek a definition that would capture these dimensions to be able to guide the way we retrieve our information, analyze, and present our results. There have been several skills that have been developed to attempt measuring health-related quality of life of people living with HIV. In fact, a systematic review in 2017 identified 7 of these HIV-specific skills, of which they highlighted 2 as being most relevant to people living with HIV, the PROCOL instrument and the WHO instrument. For this review, we retained the WHO instrument also because of its cross-cultural validity, which defines 6 domains of health-related quality of life: the environmental, the social, the psychological functioning, the level of independence, the physical functioning, and spirituality, personal belief, and religion. We went forward to conducting the scoping review using the 5 steps proposed by Aske and O'Malley. To develop the review question, we used the PICO approach. Our populations were adults living with HIV. Our phenomenon of interest was fourth 90 and related interventions, and our context was sub-Saharan Africa. To get relevant studies, we developed a search string with the terms HIV, quality of life, and individual countries in sub-Saharan Africa. We went ahead to search 2 databases, PubMed for its wide biomedical literature that it offers, and Wiley for additional life and social science articles. We knew upfront that the fourth 90 target was a relatively new topic, so not much published on it. So we anticipated to do a manual search. We went ahead to come up with the criteria. We were interested in articles that quantitatively assessed health-related quality of life using the WHO instrument, and interventions that improved at least one area of health-related quality of life. We chose a period of 10 years to capture recent evidence. We then charted the data and summarized the results. Our database search yielded about 1,788 articles, out of which we removed 98 duplicates. We then went forward to do a title and abstract screening and a full text evaluation, and after excluding articles that did not meet our criteria, we retained 26 articles, out of which we added 7 to give us a total of 33 papers for analysis. Out of the 33 papers that we included in the analysis, 7 were discussing an ongoing debate on the 490 target, 3 were view points, and 4 were peer-reviewed. Out of the 9 studies that were discussing health-related quality of life domains and determinants, 2 were prospective and 7 were cross-sectional. Finally, the 17 studies that were discussing interventions were both experimental and descriptive studies, using both qualitative methods for most, but also quantitative and mixed methods. Now, for the 7 papers that were discussing an ongoing debate on the 490 target, they illustrated that though the 490 target proposes 4 areas of intervention, decreasing discrimination at the health facility, integration of other services with HIV services, and engagement of civil society, the issue that brought about a debate was indicators to monitor the new target. So stakeholders raised concerns about how this will be done in real life. If we look at the first 3 targets, they seem quite straightforward. Either someone is diagnosed or not, placed on treatment or not, or virally suppressed or not. But with a health-related quality of life, it is multidimensional and subjective. So they were worried how this was going to be measured. So for the studies that were discussing on domains, they all use the WHO quality of life instrument to measure health-related quality of life, giving each domain a score on 20. To come up with this graph, we summed up individual domain scores in each study, and then divided by the total number of studies to give us the total mean scores. And we realized that spirituality and the physical domain stood out as having the best scores, depicting the strong personal convictions and beliefs and doctrines of people living with HIV in this sub-region of Africa, and the physical depicting the success of the ART program in ensuring good clinical health. However, the social and environmental domain stood out as having the lowest scores. The environmental looks into issues of safety, home environment, transport, access and quality of social and health care, and opportunity to get new infection, new opportunities, skills, and so on. So for the determinants, there were several determinants that were associated with a higher quality of life, and there were others that were associated with a lower quality of life. There were even some determinants that were associated with both. But what I want us to note is that there were 3 determinants that stood out as being very significant because they did not only improve one domain, or they did not only affect one domain, but several domains. We take ART, for example. Being on ART improved several domains of health-related quality of life. Depressive symptoms, on the other hand, negatively affected health-related quality of life, as well as stigma. From the literature, 3 definitions of stigma emerged. Self-stigma or internal stigma was when people living with HIV absorbed negative messages and applied them on themselves. Anticipated was when people got scared to get tested for fear of being stigmatized in the future. And external or enacted stigma was the negative attitude that other people had towards people living with HIV. So for the interventions, we classified them according to the domains that they most impacted and the level at which they were offered. The micro for the individual level, the meso for the community level, and the macro for the structural level. Now, talking about the environmental domain, the domain most affected, we clearly see that there were not many interventions that significantly improved this domain. Before I go forward, I would like to say that for these interventions, most of them improved either health-seeking behavior or access to ART, so improving the continuum of care. Now, for the environmental domain, interventions such as community ART group, which were small groups of people living with HIV stable on ART, where one person was designated at the end of the month to get refills for the other members of the group, improved on transport costs, for example, decreased overcrowding at health facilities, and also the negative labels that people living with HIV could receive at the community because they were always seen at the HIV clinic. For the social domain, there were interventions such as peer HIV community support workers, who were people living with HIV trained as community workers who went into the community to give refills to people living with HIV and could better relate with them. And then there were interventions like social networks of people living with HIV, but also mixed with people not living with HIV that enhanced social inclusion. But one thing I want us to note about such stigma reduction interventions is that they greatly improved on internal stigma, but less on external stigma. An intervention like mass voluntary counseling and testing improved on anticipated stigma because people could know their status. For the psychological domain, it was the domain that had the highest number of interventions. So this could probably explain why it had a better score compared to the social and the environmental domain. There were interventions like peer counselors who were also people living with HIV who provided counseling to their peers and acted as role models, motivating them to begin their treatment. Care supporters and treatment partners were designated family members or friends who help people living with HIV adhere to their treatment at home. There were also support group meetings that enhance sharing of experiences and peer motivation. Other interventions like decentralization of HIV services, person-centered care approach, and depression care improve mental outcomes in people living with HIV and improve person experience. For the physical domain, interventions like home-based rehabilitation programs and nutrition education programs improve physical well-being. The ART program on another part improved several domains of quality of life, but also improved enacted stigma because it permitted the community to view people living with HIV as being healthy. So for the recommendations, we have seen that improving health-related quality of life, improve health-seeking behavior and access to ART. So we urge stakeholders to collaborate in implementing such strategies to improve the health-related quality of life of people living with HIV. And we have seen several examples of such interventions. However, we identified gaps, especially in environmental-related interventions and policies. So we recommend that researchers put more emphasis on development of such interventions so as to improve the overall health-related quality of life of people living with HIV. And finally, because we saw that the debate was about monitoring of indicators for health-related quality of life, we encourage future research and researchers to test hypotheses on the monitoring of indicators for health-related quality of life. We have seen some skills that can be used to do this in routine HIV programs. So thank you.
Okay. Okay, thank you, Tatiana, for keeping the time and for your very informative and brief presentation. I don't see any open questions. Here now I see some questions here. The first question I see here is referring to interventions relating to the psychological domain. Jockey is asking what were the activities at the Meso level to reduce stigma. So he's also asking for if you could give some concrete examples, you know, from the literature about stigma reduction, basically.
Okay, so for stigma reduction, there were interventions like the networks of people living with HIV. So people living with HIV created networks amongst themselves where they could carry out activities just to bring about social inclusion and not to feel left out. And also there were networks of people living with HIV mixed with people not living with HIV, so as to reduce the stigma, to educate these people that people living with HIV can also relate in the society like normal people. So these are the kind of interventions at the Meso level that brought about social inclusion and stigma reduction that I could find from the literature. And there were also interventions like people living with HIV being paired with close members in their community so that they could help them adhere and interact and include them in several activities. So this were some of the significant interventions that we could find from the literature. But again, I would like to say that they significantly improved internal stigma. That is the way people living with HIV see themselves, but yet did not have a lot of impact on external stigma, the way the attitude that others. So those who were involved in the networks changed their living but people who were not in the networks kept stigmatizing people living with HIV.
I think that's a very interesting observation, because it means, in other words, I think it means that we would have to do more really in the community to reduce stigma, right? So
yes,
not burden people living with HIV to also kind of, you know, deal with the stigma in the community. So, but I guess this kind of research or interventions like that, of course, they were not included in your study because they wouldn't fit your own search criteria. But it's like we could say that this type of stigma reduction really is a responsibility of the society at large, right?
yes.
So here I have another interesting observation, which is from Gerd. He says, "Thank you for this interesting and needed study." And Gerd actually he coordinated a survey of quality of life among people living with HIV in Belgium. So he knows this data very well. And he said, we found that 50% of the people that participated in the survey had no partner, and that this highly affected social support and mental health. So he was wondering, is this an important thing to keep in mind? What would you say, Tatiana?
Yes, definitely. It's an important thing to keep in mind, because I think it still goes back to stigmatization. Probably people don't want to be with someone once they know their status, even though now we know that if people take their treatment they very well and they achieve viral suppression, there's a negligible risk of transmitting. But it can also come from people living with HIV themselves being scared to, review their status or pass on the infection to their partners or to their babies. So this is a two-way thing that we should look at, both at the level of people living with HIV, but also still with the issue of stigmatization in the communities.
Yeah, and also would you say, like, this is an observation I can share from our own prevention project for people of sub-Saharan origin living in Flanders, where we also have a patient support group. And what we very often see is like that people who are living with HIV, they kind of prefer a sexual partner or a relationship with another person who is HIV positive, which on the one hand, I think it's very logical because they share the same experience. And they live in the same situation, they have the same challenges, but it's also a kind of limitation. Do you also observe that, for instance, in your hospital?
Not quite, because here everybody tries to hide their status, so no one wants to review, because normally if it was in a situation where people could freely talk about their status, then maybe they can find other people who are also HIV positive. But in situations where they come to get their refills, this is the only place where they could meet. But otherwise in the communities, they don't go around, they don't get together because they are scared to be stigmatized. So it's really, it's not very common here.
Okay, I see another interesting question here in the chat. Again, more related to external stigma. Could you comment? What do you think would be possible interventions to better addressing external stigma?
Okay, so it's going to be indeed complicated, but it can be done again at several levels: the individual level, the community level, and the structural level. If we look at the community level, we have already seen some examples which didn't seem to have a great impact. But for our study, I would like to say that there were some examples of these stigma reduction interventions, like education in schools and in other institutions, but they were not included in the study because they did not improve any particular area of health-related quality of life, so they were not included. But there are many of these examples, but the problem we have with them is that they don't have a lot of impact. So in my own point of view, I think that one of the things that we saw lacking in the literature for sub-Saharan Africa were really policies to protect the rights of people living with HIV. Because if you are living with HIV, for example, you might lose your job, you might not be accepted in school, you might not be allowed to attend certain activities or even to travel. I think that this is a good place to start with. Another way that I think that we can try to work on this stigma is really also making it policy bound, like the 3 other targets. If we make it policy bound, then every nation will try to achieve this by developing interventions of their own and try to see how to really normalize this stigma, and also involving people living with HIV in several activities so that they come up. They are not scared to come up, telling them you can get a job or this, and if this will permit them to come up more and speak for other people living with HIV. I think that there's still a lot of work and a lot of research to be done on this and a lot of interventions to be tested, but we could start from there.
So you're saying, first of all, getting the legal framework right and having anti-discrimination an anti-discrimination legal framework in place.
Yeah, like
right?
punitive laws against people who discriminate, and then making them know that they should be included, like inclusion and diversity should be promoted, especially for people living with HIV, so that people start normalizing this infection.
Yeah, okay, thank you very much. Maybe I could add also from our own experience here in Belgium, from our work with people from sub-Saharan African origin here, we recently have developed with the HIV project, so that is this HIV prevention program. We have developed a stigma reduction intervention using social media and also other media like posters. So this is then really for the community level, because we have seen that also in the general community there is a lot of, you know, old prejudices, ideas about people living with HIV passing on the virus. So there is also quite some stigma on the community level, and we have used the co-creation design to, together with people from the community, develop messages and then use these messages on posters, on leaflets, and in little social media campaigns, also doing kind of small videos that they can post and share. And so we would be hoping that this can also effectively reduce the stigma at this level, although up to now we have not yet had the funding to really evaluate that, but we're hoping to get that funding. So I have here in the questions and answer chat, I see two more two questions that relate more to your methodology. The first one is if you were able to compare health-related quality of life outcomes across different groups, for instance, adolescents or pregnant women or children, or if you have any idea about how that is positioned in the research you looked at.
Yeah, unfortunately, we couldn't do this comparison because for our study, we were concentrating only on adults living with HIV. So we didn't include adolescents. For pregnant women, if they were adults, then they could have been added, but we didn't include adolescents or children because it seems sometimes because they have carers, they have quite specific or different needs. So they were not included in our study.
And can you share some insights on gender? How does gender affect the self-perceived quality of life? Any?
So yeah, from the literature, I would say that we had studies. This was one of the determinants that was associated both with a higher quality of life, but also a lower quality of life. So some literature supports the fact that females, because of gender issues, don't live, the experience of HIV, it's a little bit harder on them because of the females, so they leave it worse than the males. But on the other hand, some literature said females were instead stronger mentally when it came to living with HIV compared to males. So they were more adherent to their treatment. They will come to the clinic. And also because their hopes of procreation, having children with no HIV has really motivated them to, get their treatment and fight for survival. So that's what I can say. And most of the patients were females for this study.
Okay, thank you. That's interesting. There is another question here. Abdel Assisiri says, thank you very much for your nice and interesting presentation. He's specifically asking about the score that the WHO measure is using. He says in slide 12, could I know more about the method of calculation of mean score? Does it exist? If there was a significant difference between the frequency of the 6 dimensions of quality. So if like you had split it up and you had differences, like you said,
okay, no, so
environmental ones were the lowest, but was this significant?
Yes, so for the calculations, if I understand the question very well, there is it's using a questionnaire. So there's WHO instrument that uses a questionnaire with several questions for each domain. So for example, the social domain will have about 4 or 5 questions, and then it will be scored first on 5 and then multiplied. You'll be scored first on 5 and then multiplied by 4 to give a score on 20. So this will be the score for each domain. So about the significance, for this study, we retained only statistically significant determinants which were associated with the domains. So there is if you look at it, you look it up, there is a whole, it's a bit complex, there is a whole questionnaire and with codes on how to ask the questions to the patients, but all the questions are answered by the people living with HIV. So they answer and it's according to what they tell you that you score, because there are various categories. And then from using that, you will be able to give a total score for each domain. So for every study, they gave already a score on 20 for each domain. So we just added it up and divided by the total number of studies to get the average, like the total score, to come up with a graph. So I don't know if that answers the question.
Okay, thank you. Well, I don't see any concrete questions anymore. Are there any other questions, or it doesn't really have to be a question? So if people are just, you can just share your remarks, maybe some experiences from your own countries regarding stigma, discrimination which appears to be one of the main factors to impact on health-related quality of life. We would also be interested to learn from other people's experience in this regard. But maybe while people are thinking about additional questions or contributions, let me also ask a question about the environmental domain. As you said, this is one of the domains that impacts on health-related quality of life, but there are not that many interventions out there. And what you also said that access to healthcare is included in that domain, right? Is also like, let's say, from the literature you studied, do you have any, can you give any insights into stigma and discrimination as people living with HIV perceive it directly in the healthcare setting? Was that also a topic that that came up?
Yes, that came up. So I can talk about it both from the literature, but also from experience. So the thing is, at the level of the health facility, there is also a problem of stigma and discrimination, because the healthcare workers, especially those who are not well educated, well, maybe not well educated about the topic, because they are, but so I'm sure it's just that they are scared of maybe being infected, or just that stigma. So what happens is that if a person living with HIV comes to the health facility, maybe no one wants to come and attend to them if they know their status, because they just maybe are scared to come close to the person living with HIV. So this is one example. Or if maybe they have been hospitalized in the ward, they will have less visits from health professionals compared to those who are not HIV positive, and they might also be isolated. So all this makes people living with HIV to be psychologically distressed and not wanting to come to the health facility for services, or makes them to hide their status and not want to reveal it once they are seeking for medical attention. So these are some of the examples. So this is one of the things. If you see for the 4 proposals of the 490 target, they propose this, reducing discrimination and stigmatization at the health facility, because this can easily be tackled with health professionals should better understand what the infection is all about, and can better work on stigma and discrimination. And so there is this approach, the person-centered care, that tries to address this by having workshops with people living with health professionals on how to care for every patient, not only looking at the clinical aspect of the patient, but also other social and environmental factors that could hinder them from maybe taking their treatment and so on. So this was one of the examples from the literature that came up.
Yeah, and do you think this is okay? It will always depend, of course, how the healthcare for people living with HIV is being organized. But for instance, I think in Belgium we have we don't really have, as far as I know, but maybe Geert would know, because probably this is also a question that was probably addressed in the survey among people living with HIV, to which degree they perceived any stigma or discrimination in the healthcare setting. But I think in Belgium it's more a problem for the non-specialized, non-HIV specialized healthcare settings, whereas the HIV specialized ones, they know the problem well, and they have this kind of patient-centered care approach, and are dealing quite well with people living with HIV, but not necessarily the gynecologists, the dentists, and other professions. And yeah, I think we also really would need interventions in this area. And I think currently there are also some interventions are being developed to tackle that area. So I don't know if any other participants would like to share experiences on stigma in the healthcare setting.
I think another example is even also at the HIV clinics, because people living with HIV will often complain that they are being scolded at if they miss the pill, or they don't talk to them like maybe they will speak to other other patients. So, but this is in the HIV clinic. So this is about people who know the disease and know everything. So this kind of attitude can also make them shy away from coming to the health facility. So I think involving people living with HIV, training them as community health workers is also something that can help, because they best relate with people living with HIV, and then maybe they will feel more comfortable talking to someone who lives the same situation as them than someone who doesn't.
Yes, I think that would be. I mean, there is also, we also know that from psychological stigma theory. Yeah? There is something that is like we can refer to that is called the contact hypothesis. So showing that people have all kinds of ideas about other people. For instance, about people living with HIV, and that is maybe all the stereotypes they may have about them. But once you really know somebody, very often people are like, oh gosh, I didn't know that this person is HIV positive, or that this person is living with HIV, and it's such a nice person, and that really also changes the stigma. So I think community-led initiatives and people living with HIV who can really work as role models and be in touch with in this case healthcare providers could really be a good approach to tackle that stigma. Because yeah, it's really surprising that healthcare professionals would still hold such stigmatizing attitudes after so many years in the HIV epidemic. There is another question from Joki Bahati. At international level, some of the countries are still requesting negative HIV tests for getting travel documents, which discriminates people living with HIV. Is there any debate on that at the global level?
Well, I don't know if there is a debate on that at the global level, but I think this is one of the points I was trying to raise about discrimination. Because if we make such policies, in some countries here in sub-Saharan Africa, you will not travel if you're HIV positive. So this is one of the tests that is required, and once it's positive, you will not be allowed to travel. And this is exactly what we are talking about, because there is still that stigmatized discrimination at that level. So for me, it's really, it should be a global debate, because this is one of the things that will not help when it comes to trying to fight stigma and discrimination. And we know that now we have actually moved up to the 95 targets for the 2030 agenda, which advocates for zero discrimination. So we will not make it there on time if we don't address these issues. So this is why it was also very important to analyze what are the challenges we are facing, because putting up the targets is quite beautiful, but we need to address the challenges to be able to actually attain them.
Yeah, thank you. Yeah, I think just to add on that, I think there is a global debate, but I think in this, as Tatiana also says, despite all those commitments and the frameworks that are existing and the targets, what happens on the ground is quite often very different. And yes, we have all those human rights-based approaches in place, but even if countries commit to them, it doesn't mean that on the ground these policies are always implemented. So there is still a long way to go, I think. So that's correct. And what I also wanted to add is, indeed, there is not, this fourth 90 has not been implemented, but as you rightly say, you refer to zero discrimination. And I think that in the new UNAIDS strategy, there is also a kind of a proposed target of stigma reduction, so that less than 10% of all people living with HIV should experience stigma and discrimination. So I think that is a kind of a target that they also introduced, but it's not. It's measuring stigma, but it's not related to quality of life as it would have been with the proposed fourth 90. I see another question. It's from Lazar Manerankunda, who is actually a colleague of us and also with the HIV-SAM project, prevention project I mentioned before. He asks, what is your opinion about the awareness of professionals about stigma and its negative impact?
Okay, so I think that we still need to do a lot when it comes to awareness of professionals. I don't know if he's talking about health professionals, because because if people are stigmatized at the community and there is already a lot of work to be done there, but they should not be stigmatized or discriminated upon at the health facility. So in my opinion, this is really unacceptable, and we have to put more efforts on creating awareness. And even though we know that the professionals know, but creating more workshops, more seminars, more conferences on this, where we invite all health professionals, and maybe trainings on person-centered care. So this can also go a long way to help with this awareness. And I will keep insisting on the fact that I think it's important to include people living with train people living with HIV as also professional providers, so that they also work amongst colleagues, and maybe this will also reduce stigma and discrimination.
Yeah. Okay, thank you. I think also we should always be aware about stigma does not really equal discrimination. Maybe to a certain degree, it is maybe even easier to fight discrimination, because discrimination is really something you can see. It's like it's an act, it's behavior. So and it's very important that we have, for instance, these anti-discrimination laws in place, as you rightly mentioned. But stigma is more subtle, and stigma can also, it can just be how you talk about somebody, the look you give somebody, which can have a tremendous emotional and psychological impact, and that's much harder to change, I think. So I think we need to invest also more in that, but it's in any case, it's certainly true that we have to work on all levels, and we need the legal frameworks, and we need the community work, and because it's a complex issue which can only be solved if we work on all the levels at the same time, I think. So I don't know, I don't see any open questions. And I think I also somehow run out of questions, really. So Tatiana, do you have any last burning issues? Any take-home message you want to give?
Well, I think we've already said almost all of it, but what I just want to stress on is that one of the themes of the SDGs is that leave no one behind. So I think that as much as the sub-Saharan African region is having challenges in testing and treatment, we should give a minute to look back to see which nations are those that are lacking behind, so that we see what should be done so that they meet up, because now we are already at a 95 target, whereas sub-Saharan Africa didn't even succeed for most countries to attain the 90. I think they're being left behind, so something needs to be done about that. I think that is my take-home message. But if not, we already see that this issue of quality of life is very important. We've seen how it affects viral suppression, and this is the reality. So I think we should start paying more attention to this, because if we want to effectively control the HIV epidemic, we have to address this psychosocial aspect.
Okay, thank you very much for this advocacy statement at the end of your presentation.
Thank you.
I would like to thank you for the presentation. Very interesting, very nice. I would also like to thank all the people who asked questions and who contributed to the discussion. Thank you very much for your attention. Charlotte, do you want to say something to end?
Yeah, I just wanted to briefly thank you, both Tatiana and Christiana as well, for the sharing insights and moderating as well. So the participants, like you did already, Christiana, for being there and for their questions. I also wanted to just flag already our third alumni webinar, which will take place on the 4th of November from again 1 to 2 p.m. So we hope we can count on your presence. It will be with MTM alumnus Jahan Malik. So make sure you save the date. And we thank you also in advance for completing the short survey, which will be displayed shortly after. In the meantime, as always, stay safe and healthy, and looking forward to seeing you again during the upcoming webinar. Thank you.
Thank you.
Bye.